So, good morning to all. So, my talk will be on the EGFR mutant lung cancer. So, this is a brief talk. So, let us review what is the diagram of first-line EGFR+ve cases of now, how to manage resistance, and what are the combination strategies which are available for us at this time. So, the EGFR story is a long one. So, initially, the trials were they were not aware of the importance of the EGFR mutation per se. So the new drugs were there, decades were there. They tried against the chemo, but the difference was not that great. So later in 2004 was the initial EGFR module showed the importance of this mutation and whether and what's the importance of selecting the drug based on the mutation per se. So this was then NSCLC patients of response to definitely. So just EGFR, because that's the main thing we'll be talking in the next 20 minutes or so. The EGFR activity mutation, particularly in the intracellular domain, so the tyrosine kinase from 18 to 21 are the most important ones. Usually most of them are in the exon 19 and exon 21. And exon 20 is still a problem, and we see many resistant mutations also coming up there in the exon 20. That is a T790, which is the most important one there. So it's a very small segment of EGFR which is relevant for block. So Tony is the main person here. We see all the trials starting from the initial Japanese to the osimertinib and even the later ones. So the initial one was this bypass one, where there were chemo-naive patients in the NSCLC. They were randomized to Japanese or carboplatin paclitaxel. So what they understood was that they compared in the individual population, the PFS of carboplatin versus Japanese was almost same. It was the whole population was taken as 5.7 versus 5.8 months. But this time was the most important one, where they understood that it was the EGFR mutant population which was getting the benefit. In the EGFR mutant, hazard ratio was 0.48. The PFS was 9.5 versus 6.3. But more importantly, the wild type actually if you Japanese, then we are getting inferior PFS. So this is again one thing which is really relevant, because maybe even a couple of years back when the tests were not available, there was a tendency to just prescribe Japanese without a biopsy and without knowing the images. So actually we are doing this is to the patient, because in them actually the survival is better if you are giving them chemotherapy, because that ratio is 2.85. So this shows. So this was just we knew about this. It seemed to be a long time, but it was just maybe 10 to 12 years back that we understood that EGFR is such an important thing. So after the first generation, that is the EGFR, I'm not going to the other because the seems to be not a common use nowadays. The toxicity is there. So the second generation came, that is updating. So let's then 3 and 6 again turning more group. So here the one was against system and the other was against system. The less than 6 was particularly only in the East Asian or the Asian population was in the less than 6. So that's the difference there. So this was the chemo region was also slightly different. That's not the difference between these two. Otherwise, the selection criteria all were same, all were EGFR mutant. The responses definitely were better. So that's again one thing which we see about among all the drugs. The responses are very much improved when we give the target therapy. The PFS is around 11.1 and the overall survival are 28.2 months. This is just to summarize what is the data of first time. So definitely bypass and first signal, then the optimal and yield type are about the aerobic and less than 3 and 6 are about the affinity. So all these trials I think were read out over a period of maybe 6 to 7 years time, one by one they came, and all of them showed the same thing, similar that the responses were much better with the indicator of the TKA. The PFS was also, you can see uniformly around 9.5, around the least was 8, but gross is around 10 to 11 months. And the overall survival, because the crossover was there, because it was there in the trials, the design and stuff. So because of that, the survival difference we are not seeing of major difference. So that was the review. So the newer ones which we have is dacometinib, which we all started to use nowadays. For various reasons, where the patient can't afford osimertinib, some of these patients are getting dacometinib. So dacometinib was it's a recent one, maybe in 2017 was when the trial came out. Again, I think the criteria say EGFR mutant first line treatment, patient without brain mets were randomized to 45 mg to 250 mg. So what it showed was again it was 16.6 months of daptomycin versus 11 months with Jeffrey. So there is a slight advantage is there, but again the problem was that it was not CNS activity is not there. So the main issue that which we know is the side effect profile of the drug. So the treatment related the serious adverse events were very high here. The dose reduction was given almost 66%. That is a big number. So that's why practically even if you asked the company, we were minimum practically only 30 mg because even the trial or around 38% received 30, while even 15 mg was given to us. So that seems little unusual because we know about the story of certainly where it was started at 50 mg was not at all tolerable. Now then it came up to 450 and patient taking that. So maybe the same thing will happen, but we don't have guidance as of now to tell that. But maybe 30 mg only seems to be a tolerable dose, and even the trial almost 66% had dose reduction. I am not sure whether they are planning to reduce our trial. Not sure about that. So that is about up to daptomycin. Then coming to the question of resistance. The majority of resistance is because of the EGFR target alterations, and the main one being T790M, that is around 40 to 55%. And we have a lot of other bypass tracks are also activated, like VRA, amplification, TIP3, all these things are there, and small cell carcinoma transformation also we are aware of that. So how to tackle this resistance is the next issue. So that is where ORA3 was again in 2016. So that was ORA3 was it was evidence of disease progression following personal EGFR PK. So we had osimertinib one off and platinum pemetrexed plus maintenance pemetrexed in the other. So the PFS by investigator was with chemo. So after progression, they had just 4.4 months of PFS with the chemo, while with osimertinib it was around 10.9. So after this, Flora came. Flora was in an upfront setting, so no prior therapy was there. So again, the osimertinib versus Jeffrey or allowed because that was standard. So Flora showed that the PFS was 18.9 months versus 10.2 months. So this actually simulated the position of osimertinib, and that is still continuing as the best TK that we can offer to the patients. Is 18.9 months PFS with osimertinib. So adverse event profile actually we all know that it's a tolerable drug. Actually only the dermatitis is slightly less, and the NSCLC changes are also slightly less with osimertinib. So actually we never look for this. Practically this much of the NSCLC elevation is there with Jeffrey was a new thing that I understood from this, but again that side effect is also a little less when we are giving osimertinib. So these are the two main differences, but we all know it's a highly well tolerated drug. But osimertinib is also not the final thing because again resistance can develop with that. The PFS is around 18 months only. They can get both on target with additional EGFR mutation like C797S, where there are trials ongoing for that. There can be EGFR independent also. It can be due to small cell transformation, the same thing, which is only for an alternative pathway. So the similar things can happen even when the patient is getting osimertinib. So how to deal with that? So there is an option. This is what the response says. So it's a very slow progression. We can continue osimertinib. Patients doing well. We all see patients have a small, the PET scan shows a small change somewhere. Then maybe immediately jump and change. We can continue and see how it is going because practically there is nothing great to offer after. Maybe that's the reason for that. And if it's not a serious progression, then we can local approach. We all give variations, BRBs, and then continue with the drug. Practically, we will do that. Small site, give variation there, and continue with osimertinib. If it's a serious progression, then we can look for SRS, and then again continue osimertinib is an option there. And if it's not, if the patient can make a try, but that's the best thing that we can do. And the rate biopsy is also an important thing there. So I think, same similar thing, where there are drugs to offer. We also see patients. I had a patient with EGFR, then he developed a VRA mutation. Then we combine the VRA inhibitor and the patient lived for 1 year. So all of us have such patients who we are able to re-biopsy, get a second mutation, and whether to continue with osimertinib with an added drug or not, or change all these things are practically we are doing nowadays. When the option of re-biopsy is possible, and liquid biopsy also helps us. So now the other things, whether we can add anything more to the EGFR comes here. So one thing is anti-angiogenic because anti-angiogenic is involved in the tumor mediator, which promotes resistance to the drug. So that is where this the combination of bevacizumab comes in. So Arun plus bev was one of the things which was highlighted. So this also was published maybe this also came a couple of days back, where it showed that there is a if you combine bevacizumab, we can have the median rates of 16.9 months, while the Arun was 13.3 months. So the survival again because of the crossover we are expecting that here, but the PFS there is a few months advantages there when we add bevacizumab. And the ramucirumab is also being tried again with the combination dialogine. So that again what they showed was that there was maybe 5 to 6 months improvement was there. But this all was maybe once osimertinib came into the picture, then all these trials maybe was not accepted or the common practice not there, and we are all aware of the problems with the bevacizumab, the proteinuria, all these issues, and osimertinib may be slab problems. So then the chemo plus EGFR TK. So that is where the PMS group and then there was some Japanese both came simultaneously in 2020 JCU. It showed that at that time the standard of care in the trial was decided was deftinib. So they added deftinib to carboplatin. It showed that the PFS improvement was there. It was very dramatic, but it was there. The overall survival was also significant. So, but then by the time 2020, the deftinib was not standard of care at all. So what to do for that? So then Flora came. Flora came last year, 2023 was the publication of Flora 2. When again it was osimertinib plus chemo, plus maintenance osimertinib plus chemotherapy. And the other one was osimertinib. So Flora 2 was actually proving what deftinib also we knew from that. So the PFS was significantly improved when we combined osimertinib by 25.5 versus 16.7. So gradually over 10 years, they are coming from 11 months to 18 months to this, we are coming to 25.5 months. So gradually the PFS is improving. And because of the CNS penetration of osimertinib, it was even with CNS medicine also, it was the same thing was seen. Voice is definitely not reached as of now, so maybe a couple of years we have to wait for that. But maybe it may not change because patient condition. And this is a tornado graph. It shows that when we combine the power of two, we are to face the side effects of both. So that is there. We had assessed the neutropenia will be there. And the pemetrexed, we know when we give for a long period of time, the bone marrow oxidation can kick in at some point. So that is an issue. So the tornado shows that we are combining the power of both and we are getting side effects of both. But pemetrexed, we know how to manage that, so maybe it's feasible to manage that. But also, is also a good drug to do in the long term. So we know these drugs are there. These are the ones which are there in practice, and people are trying combining with bevacizumab and all these things are there. But is that then? So then the new one comes. That is amivantamab. So that is the latest drug for the EGFR space. So the amivantamab is a dual blockade of EGFR and MET. So MET again is around 5% can develop this mutation as part of the resistance. They can have after also. So both dependent and independent mechanisms are there. So the videos of amivantamab. So we have Mariposa 1 and 2, just a few 1 or 2 slides. So amivantamab is an IV drug, so that's an issue there. So the so there is a 3-arm, 2:1 randomization was there of amivantamab plus lasatinib, so and plus osimertinib, and the other one was the lasatinib. So it definitely showed that amivantamab, when we combine that, the PFS is improved. So the idea was that we can avoid chemo, because with chemo, we know that it's around 24 months we are getting. So no one likes to give chemo, so whether we can just go for target therapy. So hello, so that was the thing they were looking here. So again, it showed that it's possible. We are able to give amivantamab plus lasatinib. We are still looking at PFS of 23.7 months. So I extra kind of papers. So to see. Safety is an issue. So then one new thing has come up here, that is a venous thromboembolism was one thing, and but the IET pneumonitis was not something which they were worried of. It was not right. Otherwise, it was mostly grade 1 or 2 side effects. So venous thromboembolism is a new thing here. When the trial was initially done, they were not receiving that, but now they know that we have to give prophylactic antiviolence also we are giving amivantamab. So my postulate 2 is there, in which the patient will progress on or after osimertinib monotherapy. Because after osimertinib monotherapy there is nothing much he can offer as of now. Other than giving them chemo, so amivantamab, lazertinib chemo, or the chemo only or chemotherapy was there. So again, last year it came and it again showed that the PFS is improved. That is but maybe in the second line setting, we are not seeing that much of a dramatic change. 2 months change only is there, but for 4 and 6 months, the hazard ratio is 0.48. So if you are giving the, maybe we can give it. So yeah. So basically, the main thing is that we all know we have to screen. That is definitely yes. Novel options are coming to make your practice, and just the vaccines and so there's a new thing which are coming up. So it's still not the end. So new vaccines and all are being tried, and we are seeing phase 2 trials being done in NSCLC. So a lot of actions to remaining. Thank you.
Thank you, sir, for the informative presentation. The session is now open for discussion.
Most of the baseline patient, elderly patient, is not fit enough to take chemotherapy. So we start, if EGFR is been applicable, we will start EGFR directed therapy. But when the patient is recovered from the lung cancer itself, and after certain time, if the disease is progressing, can we add along with EGFR directed therapies chemotherapy? Because none of the trials are done in that direction.
So even after progression to add chemo to the EGFR therapy, because if the disease is progressing on EGFR, the diagnosis is already resistant to EGFR. So there cannot be any point in adding them. It's resistant to the drug. So what's the point? We will biopsy, good, but still if it shows mutation, because adding chemo at that point may not be. Because
doubtful progression.
See, the problem is we have to do a biopsy. Like my experience was that one patient progressed on
for example, in brain we are giving SRS, but in systemic setting, if there is suspicious progression.
That's what. If there is a very slow progression, is an option of continuing EGFR is there.
Along with that, can they add chemotherapy?
But why?
Because chemotherapy will take care if there is real progression also. Can we do that? Can we practice?
We usually follow is if there is a resistance on any of the anti-EGFR therapies and we see on PET CT there is enough progression, we usually nowadays practice liquid biopsy to see if there is any additional mutation which has come up or is there any resistance mutation which has come up, and then we plan the treatment according to that. So that is an option that
we wanted to know whether we can give chemo and TK together.
It is actually based on after we do the screening and the NGS testing, and then we can decide accordingly.
I want to ask, when a patient is coming in treated with new patients, how do you discuss the patient to the patient?
Which drug to use?
Which drug use?
We are giving options osimertinib because many of them may not be able to afford. That's the problem. We tell them these are the options. Not an easy.
Clear question. Thank you.